Hello, I'm Bunsen. Welcome back to this medical education channel. Today I'll be talking about the approach to increase cell count, and this mini lecture is specifically catered for undergraduate medical students doing their internal medicine rotations. There are three learning outcomes in these sessions. Number one is to describe a logical and practical approach to assessing patients with increased cell count, list the differential diagnosis, and describe the overview of the management, specifically of secondary polycythemia, acute leukemia, and reactive thrombocytosis. While it is essential to recall some of your prior knowledge to build up the understanding towards this lecture, number one is to understand the biology of cell cycle. Number two is to recall the knowledge on hematopoiesis and its regulations of each cell line, such as erythropoiesis, myelopoiesis, lymphopoiesis, and thrombopoiesis. Well, the first step in approach to patients with increased cell count is to take a good history. Patient would not usually come to you with, "Hey doctor, I have increased cell count," unless they have done a screening blood test elsewhere. The main task is to decide the appropriateness of the increased cell count, whether it is a physiologic response or it is a pathological response, and whether there is a life-threatening diagnosis underlying the increased cell count. For polycythemia, ask about chest pain and stroke, which could hint at the thrombosis caused by the increased red blood cell, and look for features of dehydrations such as decreased oral intake and increased losses from the gastrointestinal or the genitourinary tract. As for secondary cause of polycythemia, ask for smoking history. Snoring, obesity, and somnolence would point towards obstructive sleep apnea. Residing in a high altitude, hematuria hint at the underlying renal cell carcinoma. Take a medication history, specifically on anabolic hormone use, and aquagenic pruritus and constitutional symptoms would hint at the underlying myeloproliferative disease. For neutrophilia, the differential diagnosis would be a sepsis or acute leukemia, and they share somewhat similar symptoms of fever, fatigue, and they would be systematically unwell. And more so, for patients with chronic myeloid leukemia, they would be asymptomatic. And for neutrophilia, the secondary cause of it could be from a steroid use, so take a good medication history. For thrombocytosis, it can be reactive or primary. For reactive thrombocytosis, it can be caused by anemia, so ask for history of blood loss, and a reactive thrombocytosis could be caused by inflammations as well, so ask for history of rheumatological disease such as SLE, rheumatoid arthritis, and inflammatory bowel disease, and ask about history of splenectomy, and ask about constitutional symptoms if you're worried about myeloproliferative disease. Next, we'll proceed with examinations. Note patient's alertness, response to verbal pain, and whether the patient is unresponsive, which is abbreviated as AVPU. Check for vital sign, includes pain. Then we'll screen for a brief neurological examinations and check for fundus. It is to look for retinal vein thrombosis. And note patient's body habitus, whether it's cachexic or whether he's obese. Features of Cushing syndrome, and check for volume status. Note patients whether there's plethoric and a peripheral cyanosis. And look specifically for lymphadenopathy, whether there's joint tenderness, a stigmata of bleeding such as bruises, auscultate the lungs for pulmonary bruit, which would point towards AV shunt, atrial venous shunt. And on the abdomen, look for hepatosplenomegaly, whether there's ballot to the kidneys, and whether there's abdominal tenderness. The first step in investigating patients with suspected increased cell count is to perform a full blood count and a peripheral blood film. It is to confirm an increased cell count, of course, and we will look for an immature blast, a left shift in the white cell populations, or a leukoerythroblastic picture. If the patient has anemia, Please note whether it is a microcytic hypochromic anemia of iron deficiency or it is a normochromic normocytic anemia of chronic illnesses. Note whether there's a giant platelet or there's platelet clumping. Perform a urinalysis if the patient has hematuria, which would point towards the diagnosis of renal cell carcinoma. Perform a blood gas to look for CO2 retentions, and if possible, we will look for features of carbon monoxide poisoning as well as a cause of polycythemia. Check the inflammatory marker, which would cause elevations in the white cell and the platelet. Specifically for patients with polycythemia, we can check the erythropoietin level, the EPO, and the JAK2 and BCR-ABL genes, but this would be advisable after consult with a senior clinicians. If the patient has suspected of leukemia or myeloproliferative disease, we would consider things such as flow cytometry to determine the abnormal cell lineage and the bone marrow examinations. Next, I will share 3 cases published in academic journal to demonstrate the logical approach to patients with increased cell count. Case 1 will be on the secondary polycythemia, and it is a case by Cho and colleague. The authors describe a 55-year-old man who is a non-smoker, presented with 4-day history of unsteady gait, dizziness, vertigo, tends to fall towards the left. In the past medical history, patient has no diabetes mellitus, hypertension, atrial fibrillations, history of venous thromboembolism, obstructive sleep apnea, or residing in high or low altitude, and there's no heart and lung disease. In the family history, there's no arterial or venous thrombosis, there's no malignancy, no polycythemia. On examinations, the blood pressure was elevated and the patient was hypoxic, SpO2 of 85% and 2 liters of nasal cannula. He demonstrated left dysthyrochokinesia, left dysmetria, and horizontal nystagmus. The investigations of this patient confirmed that he has a polycythemia with a hemoglobin of 20.6, hematocrit of 60%. The white cell and the platelet was normal. There's no abnormal morphology from the blood film. With regards to the polycythemia, he has a normal erythropoietin and there's no gene mutations. With regards to stroke, the thrombophilia screen was normal and he has no features of autoimmune or connective tissue disease with a negative anti-nuclear antibody, anti-neutrophil cytoplasmic antibody, and antiphospholipid antibody. The subsequent investigations confirmed the diagnosis of stroke with a magnetic resonance imaging showed a thrombosis in the left cerebellar dentate nuclei. As for the source of the thrombus, the echocardiography showed there's no intracardiac thrombus, and a CT pulmonary angiography showed a small pulmonary trunk of 18 mm compared to 25.8 mm of the normal value in the author's populations. And the cause of the small pulmonary trunk could be congenital, and it has caused a severe VQ mismatch. And this has led to the final diagnosis of a stroke secondary to a polycythemia that is due to a chronic hypoxia. The specific management of a stroke caused by a secondary polycythemia is hydration, aspirin, phlebotomy, oxygen supplementations, and in all cases, treat the underlying cause of secondary polycythemia. Case 2 is on acute leukemia, and it is a case in India published by Gayatri and colleague. This case was reported by a group of dentists who described a 22-year-old man presented with increased gum size for 5 to 6 weeks associated with gum bleeding and pain. The past medical history is significant for acute promyelocytic leukemia on a maintenance chemotherapy for the past 2 years. The laboratory result shows that there's acute leukemia, and the clinical photo on the right side of the slide shows that there's a gingiva enlargement in the maxillary and the mandibular anteriorly. This case highlights the importance of clinical suspicions of a practicing clinicians on the remote presentations of severe illnesses. The specific management of acute leukemia is chemotherapy, and with regards to gingival hyperplasia, the treatment is to maintenance of oral hygiene with scaling and the use of soft toothbrush. The third case on reactive thrombocytosis is a case from Poland published by Salaki and colleague. The author described a 19-year-old man who is a non-smoker presented with sudden severe chest pain. He has history of upper respiratory tract infections 3 days ago. From the personal history, there's no anabolic hormone use, and of note, the patient has undergone a 2-monthly blood donation for the past 2 years and each time donating 500 ml of blood. The last donation was 10 days ago. On examinations, the blood pressure was slightly elevated and he has a normal BMI. The ECG shows the sinus rhythm with a heart rate of 55 beats per minute, and the ST elevation is 1 AVL and V2 to V5, and ST segment depression in 3 and AVR. The investigations has confirmed the presence of thrombocytosis with leukophilia. The patient has normal hemoglobin with a low iron level. The inflammatory marker and thrombophilia screen was normal. The echocardiography showed a left ventricular apical akinesis with slightly reduced ejection fractions, and there's a presence of mitral and tricuspid regurgitations. The team have proceeded with an angiogram, and it shows a proximal left anterior descending artery thrombosis. They performed an aspiration thrombectomy, and a drug-eluted stent was deployed. The specific management for patients with reactive thrombocytosis is to treat the arising complications, which in this case, the myocardial infarction. And next, we would focus the treatment of the underlying cause, which in this case, possible the iron deficiency from overzealous blood donations. However, it is an extremely rare cause of a reactive thrombocytosis that complicate a myocardial infarction. We have come to the end of this mini lecture on the approach to increase cell count. We have covered the presenting symptoms, examination findings, key investigations, and the principle of management in logical and practical sequence. Q&A in the comment section, and I hope you enjoyed this lecture. Have a good day. Bye-bye.